Hello everyone and welcome to this evening's Fertility Network UK webinar for PCOS Awareness Month. I'm Kate from Fertility Network UK and I'm delighted to be joined by Professor Adam Balen from Leeds Fertility, who's one of the UK's leading experts in PCOS, and Grace Dugdale, a reproductive biologist and nutrition scientist from Balance Fertility. And jointly they're the authors of the Fertility Book, Your Definitive Guide to Achieving a Healthy Pregnancy. Some of you have sent in some questions already and we're going to start with those, but if you've got more as we go, please just put them in the chat box or in the Q&A box and we'll get through as many as we can. This webinar is being recorded and it'll be available on our YouTube channel within the next week or two. So Adam, I wonder if we could start with the most basic question of all, which is what actually is PCOS?
Hello, Kate, and thank you very much for inviting us to join you today. So Polycystic Ovary Syndrome is a syndrome. So a syndrome basically is a collection of features that can come together and cause a variety of problems for different women, and not all women with PCOS have all of the symptoms, and also the symptoms can change over time, and certain symptoms may be more important to you at different stages in your life as well. So when we talk about syndromes, we mean a list of different symptoms, and the main issue for women with polycystic ovary syndrome is that their ovaries are full of a greater proportion of the little natural cystic structures that we also call follicles that contain the eggs. And so a polycystic ovary has many of these tiny follicles, and I'm sure we'll come on and talk about more about that later. And then this is then associated with an imbalance of the hormones, not only those that come from the ovaries, but also the hormones that control how the ovaries work, because there are a number of complex mechanisms within the body with various internal thermostats that then control how ovarian function operates, and the imbalance of hormones then has a number of features. Young women, for example, may be troubled by acne, so an increased prevalence of acne, also unwanted hair growth on the face predominantly, but also other parts of the body, and that can change over time. Occasionally thinning of the hair on the head. So those can be really distressing symptoms. Women with polycystic ovary syndrome often have irregular periods, but not everybody has irregular periods. And of course, if you have irregular periods, or if your periods stop altogether, that has an impact on your fertility and your need for fertility treatments. And some women with polycystic ovary syndrome have a tendency to gain weight. And again, I'm sure we'll come on and talk about that. And if you become overweight when you have polycystic ovary syndrome, the symptoms are often worsened, and also the treatments that we use to try and help those symptoms often don't work so well if you've become overweight. And that can be very troubling as well. And all of these things together obviously can have a profound effect on your emotional well-being, your quality of life, and so many other aspects of your life. So we have to deal with the individual symptoms as they affect a woman with polycystic ovary syndrome, but we also have to deal with everything as a whole and try and support people with the particular problems that are troubling them.
And does everyone who's got polycystic ovaries have polycystic ovary syndrome? Because that's quite common, isn't it, to have polycystic ovaries?
Yes, that's a really good question. So we see polycystic ovaries on an ultrasound scan quite commonly, and a polycystic ovary is one that has more than 20 of these little follicles in each ovary. So a young woman, say in her 20s, if you did an ultrasound scan, you might expect to see perhaps 10 or 12 of these little follicles. If you have 20 or more, that means you've got a polycystic ovary, but it doesn't necessarily mean that you have the syndrome, because the syndrome requires you to have some some of the symptoms that I've just been talking about, in addition to having polycystic ovaries. And interestingly, some women have symptoms without clearly having polycystic ovaries on a scan. The ovaries aren't always that easy to see. If you're a bit overweight, they can be harder to see. So we recognize the symptoms and manage the symptoms and can define somebody as having polycystic ovary syndrome, even if we don't clearly see the ovaries on the scan. But the importance of identifying polycystic ovaries on a scan, even if you don't have symptoms, is that if you don't have symptoms and you gain weight, you may suddenly find you get symptoms. So it's, if you like, a warning sign. And also, if you need fertility treatment, your ovaries are more likely to respond sensitively to the drugs that we use. So if, for example, you're coming along for treatment such as IVF because you've got blocked fallopian tubes, or your partner's got a low sperm count, and we see that you've got polycystic ovaries without any of the symptoms, we will pay particular attention and ensure that we minimize the risk of overstimulating the ovaries.
So, given what you said about the symptoms, is it something that people could diagnose themselves, or can it only really be diagnosed by going to see a doctor and having a scan?
Again, a good question. And yes, I think you can kind of diagnose it yourself or feel that you've got polycystic ovary syndrome. And as you know, Grace and I are very passionate about sort of fertility education and ensuring that everybody has the knowledge to try and help them make a diagnosis. So that if you think you've got problems, or if you think you've got polycystic ovary syndrome, don't be afraid to go to your GP, push your GP for some tests and say, look, I think I've got a problem, and I'd like some help managing it. So yes, I think there are a number of pointers, the sort of symptoms I've just been talking about, that may lead you then not only to have an ultrasound scan, but require some various blood tests to help confirm the diagnosis and see the degree to which it may be affecting you.
And Adam, can you get different severities of polycystic ovary syndrome? And could you have mild PCOS and more severe PCOS? Is it
Yeah.
that like that?
Definitely. So I also run an adolescent gynecology clinic, and I see young women in their teenage years, which is often when the symptoms evolve. They can be mild to begin with. They can change over time, and so there is quite a big spectrum. And again, that is why we call it a syndrome, because there's a spectrum of features that can vary, that can change, and they're quite big individual variations. We see quite large ethnic variations as well. So particularly in the UK, amongst the South Asian population, for example, we see a greater degree of problems with insulin metabolism in both men and women, actually, from the South Asian community, and that can have an impact on polycystic ovary syndrome if you've got polycystic ovaries. And again, I'm sure Grace will come on and we can talk about metabolism and insulin resistance. So we do see big variations in different ethnic groups where the syndrome can affect people in different ways.
Grace, I wanted to come to you now because one of the big things that people often ask about, and I can see we're getting a few questions about it already, is around diet. And we had a question sent in from someone who says they have PCOS and their BMI is currently too high for treatment, but they're really struggling to lose weight. And is there a diet that actually works better for people with PCOS when they're trying to lose weight?
I think with PCOS, it's really important to understand exactly what's going on for you as an individual. So there are different features, as Adam was describing. So there can be signs of sort of androgen excess in terms of some of the sort of what sort of can be referred to as sort of the male hormones. There can be metabolic components where you have problems with sort of processing blood sugar appropriately, and all of these things can contribute to how things are showing up in your own body. So I think it's really helpful to have an understanding of what actually is happening. So Adam was talking about fertility education. So get through this kind of thing that we're doing, that we're talking about, and just paying attention to your body, because the foundation is obviously a healthy diet. So a Mediterranean diet is the most studied in terms of, you know, fertility generally, and is applicable to PCOS. And one of the things that people often talk about is carbohydrate intake with PCOS. So if you know that you are overweight, or you have a metabolic component to your PCOS, keeping sort of a slightly lower carbohydrate intake can be helpful, and avoiding refined carbs. So it's your white bread, you know, white pasta, white rice, sugars, and so on, because those convert very, very rapidly into blood sugar. If you're not overweight and you don't have a metabolic component, the most important thing is to avoid those refined carbs, but you don't need to sort of reduce the carbohydrate intake so much. So it's those kind of nuances, because this all impacts sort of what's driving the condition for you as an individual. So it's trying to sort of get a hold of that. And so specifically, if you want to lose weight, a Mediterranean style diet, avoiding refined carbohydrates, and probably if you need to lose weight, avoiding overconsumption of carbohydrates. And then alongside that, it's making sure that you have adequate levels of key nutrients that are important. So to keep your hormones levels working well. So zinc and magnesium are particularly helpful. Vitamin B6 can be helpful. And then there are other things like inositol that can help if you have a metabolic component. So it's a whole range of things that you can do, but it's very much about understanding your individual features and then targeting the diet appropriately. PCOS, it can be challenging because there can be gene variants that increase binge eating, for instance. So it's also kind of being kind to yourself as well, because it can be more challenging. But regular meals, not snacking, will all help. Eating nutritious foods, so you're not sort of going to sort of yo-yo dieting. These are all sort of principles that are important. We go into this a lot in the book, some of the dietary principles that help lay the foundations for healthy relationship with food, because there's always an emotional component as well. So there's lots of different components to it. So I've given a sort of an overview.
When you talk about a Mediterranean diet, could you just explain briefly what you mean by that? Because I think some people understand it and some people understand different things by it. So I wonder if you could just tell us roughly what is that exactly?
Yeah, of course. So it's olive oil, nuts, you know, fish, things like beans and pulses, nuts and seeds. And one thing that people often miss out, whole grains as well, so organic brown rice, buckwheat, quinoa, those are all healthy carbohydrates to include in the diet. And one thing that people often miss out is cooked tomatoes, which is a really important component of a Mediterranean diet. And that's really important because cooked tomatoes, when you cook tomatoes, it increases the bioavailability of lycopene, which is the antioxidant that makes tomatoes red, and that's a very healthy antioxidant, and it's particularly relevant to PCOS because PCOS can increase oxidative stress in the body. So those are the sort of key features. So fish and so having, and poultry, so chicken, and just keeping things like red meat and processed foods to a minimum as an occasional rather than a regular part of the diet. Those are things that are really important.
That's great. Thank you.
If I can come in here, and the other thing to say, of course, is the Mediterranean diet is good for male fertility as well. And we always have to remember couples in all of this. So in a fertility journey, you know, we're always encouraging couples to cook from scratch, cook together, and, you know, share, because people share lifestyles. And what all these things, they're good for your general health as well as your reproductive health, whether you're a woman with PCOS or a man and a couple trying to get pregnant. You know, I think that's really important. I was going to ask Grace. Can I ask Grace a question?
Ask Grace a question. You may ask Grace a question.
Lots of women, and I'm sure this may come up, but it's sort of relevant to what Grace was just saying, is lots of women with PCOS say to me that they get cravings for sugar because, you know, they feel that their blood sugar levels are dipping. Whereas I know that they don't ever dip to a critically low level that you might see in somebody who has diabetes, who gives themselves too much insulin in an injection. So it's never dangerous, but people get these feelings, don't they? And then they say, I crave something, I'll have a sugary drink or a piece of chocolate and I'll feel better. Yet we know that that then causes big swings up and down. So if I can ask Grace what you think. Sorry, Kate.
Great, go ahead. Grace, what would you do about sugar craving?
Relevant to what you were just
It
talking
is, yeah,
about.
it is.
Now, how do you advise somebody to deal with that sort of thing?
Yeah, really, really good question. So it's partly sort of carbohydrate as one component. So the complex carbs break down more slowly, and so give you a steadier insulin response, and will keep your blood sugars more even for a longer period. So what happens if you eat something like chocolate or sugar? You get a very quick spike of blood sugar, and then it crashes again. So the more you do that, the more difficult it's going to be to manage cravings and so on and so forth. So avoiding those kind of foods, and particularly on an empty stomach, where you all of a sudden will get a big spike of sugar from nothing to, if you're going to have chocolate, it's better to have it after a meal, because it's sort of dampens down that sort of spike and then crash. But then eating protein and fat with each meal is also helpful. So lots of people, when they're trying to lose weight, avoid fats altogether. But fat is very satiating, and particular fats and protein together. So cheese is quite good, and which brings us on to dairy and PCOS, which is a whole sort of other question. The evidence base for avoiding dairy is not as strong as you may believe if you sort of follow social media and so on. There is some evidence to suggest, but it's more milk. Cow's milk has the strongest evidence base. So cheese, and particularly things like feta cheese, you can choose non sort of cow's dairy, which may be better. But nuts are the same, where you've got some fat and protein in them, and that will help keep your blood sugars level. And the other thing is having regular meal times. Routine is really important. Your body loves routine, and your body clock is very important for all your sort of reproductive function. So, and you can kind of train the hormones that are responsible for hunger by having a routine. So having regular times, a regular breakfast time, regular lunch time, regular evening meal time. So again, lots of different components to that. And one final thing is minerals. So things like chromium and magnesium are really important for control of blood sugar.
So where do you get those from?
So magnesium, green leafy veg, is the classic one. So it's the magnesium is the key mineral in chlorophyll, which makes plants green, but we often don't get enough. And there's quite a high prevalence of subclinical magnesium deficiency that doesn't always show up in routine blood tests. So often it's helpful to supplement, and particularly for women with PCOS. So having lots of green leafy veg, but you can supplement with magnesium glycinate, 200 to 300 milligrams in the evening. And chromium is a trace mineral found in lots of foods, including things like nuts and vegetables and so on. So it's lots of different foods will have chromium in it, but it's quite easy to, if you're not eating a healthy diet, for that to drop to the lower end of the reference range. But this is where you probably need professional supervision if you're starting to look at things like chromium. But it's just to show that there are things that you can do to help support, you know, diet, nutrient levels and so on, alongside, you know, medical care. So I would always say make sure you're getting the right medical care. That's really important, and to seek professional advice, because it's not easy to self-medicate and get it right.
Brilliant. Thank you, Grace. That's really, really helpful. I've learned masses in the last 10 minutes, I must say. One question here for you, Adam, I think. Would you please explain if and how metformin could be helpful for women with normal BMI trying to conceive? Is metformin useful with a normal BMI?
Well, it might be for some, but it's not really that brilliant. Over the years, I've led a lot of research on metformin. And also I'm responsible for the Cochrane review on metformin, which essentially feeds into the national and international guidelines for the management of PCOS. So for those who are not sure about metformin, it's a drug taken in tablet form that is used for the management of type 2 diabetes. And essentially what Grace has been alluding to when we talk about insulin metabolism is an inefficiency of the body to properly utilize the carbohydrate that's in your diet. And insulin is a hormone that's produced from the pancreas in response to carbohydrate in your diet. And insulin helps the cells of your body take carbohydrate where it's used as an energy supply. So insulin, for example, enables sugars to get into the muscle where it's used to, to help the muscles work. But insulin is active around the body, and some people have what's called insulin resistance. So the easiest way to picture this is a bit like insulin being a key that unlocks the receptor to enable sugar to pass through the door into a cell. And people with insulin resistance have a rusty lock, so the insulin doesn't work so well. So the body's response to that is to produce higher and higher levels of insulin. So people who are overweight, people with type 2 diabetes, have what we call insulin resistance. And so they produce higher and higher levels of insulin to try and overcome the rusty lock. And that insulin isn't working well at the level of the muscle, so you don't use carbohydrate properly, and the carbohydrate gets turned to fat. But interestingly, at the ovary, insulin stimulates the overproduction of testosterone, which is a hormone that all women make because testosterone gets converted to estrogen. If you have high levels of insulin, that's when the polycystic ovary starts churning out more and more testosterone. So coming back to your question about metformin, metformin is used in the management of diabetes to help lower insulin levels. But unfortunately, it doesn't work that well in women with PCOS. And as I've been explaining, it's the more overweight women with PCOS who are going to have high levels of insulin. But then it's a question of you really need a very high level of metformin to be effective. Metformin has side effects. And in the context of infertility treatment, whilst metformin actually does appear to have a mild beneficial effect, it doesn't provide great benefit. So it has a role, but it was thought to be, the answer for polycystic ovary syndrome, 20 or more years ago when I started looking into it, but sadly it hasn't proven to be quite as good as we once hoped it might be. So it has a role, but not a huge role.
Thanks, that's really interesting. Now we've got a couple of questions which I think are really interesting about exercise. One person asking what kind of exercise would be recommended, and someone else asking if over-exercising could aggravate PCOS and whether yoga is better than aerobics, for example. I don't know which of you would like to answer that.
Grace is
So exercise is actually one of the things that can help improve features of PCOS, including things like menstrual cycle regularity. So you can over-exercise in terms of fertility. Over-exercising can be unhelpful, and it can lead to sort of suppression of the ovaries. That's less likely to happen with PCOS. So you're more likely to benefit from exercise if you have PCOS. So and weight-bearing exercise is particularly good and is also good for insulin resistance. So some cardio for sure. So that's sort of, your gentle jogging or running and so on. And interval training, if you're going to do cardio, is also beneficial. So if you go for a brisk walk for 30 minutes and break into a run for 1 minute out of every 10, it could be your starting pace if you're not used to exercising, or changing the intensity on a cross trainer or something like that. So it's varying your intensity can be helpful, along with weight-bearing exercise. So that could be lifting weights, it could be squats and lunges, taking the stairs, or actually, sort of having gentle weights that you lift at home, or equipment in the gym where you're sort of weight-bearing. And yoga actually is a good form of weight-bearing exercise, where you're bearing the weight of your own body, and actually can help build strength and muscle tone. So a combination of some cardio, some weight bearing, and some yoga is great.
Brilliant, thank you. Another question here for you, Grace, actually. What are your thoughts on gluten-free and dairy-free for PCOS and fertility?
There's actually, as I said, the evidence base is very poor, particularly for gluten, actually. So there's lots of debate about this. One thing I would say is always pay attention to your body, because the evidence is mixed. It's really hard to say definitively for you. And some people do find that when they cut out either dairy or gluten or both, they report benefits and improvements and things like skin and so on. So it's never ever ignore your response in your own body, and this is what I would encourage you to do, along with all the evidence and things that we can tell you. Learning to pay attention to your body and be in tune with it and understand what is going on is particularly when you have a long-term condition like PCOS, it's really, really important. So the evidence for dairy is sort of mixed. There's some evidence to suggest cow's milk is not good for PCOS, and that's the strongest. So it's not as strong as you may believe. And things like fermented dairy, like fermented yogurts, can be good for your gut bacteria. So if you want to continue eating dairy, you could try having sheep's and goat's products. So sheep's yogurt is particularly good, and it can be higher in trace elements like vitamin A, and feta cheese, and so on, and those kind of things you can try. Some people, however, do find their benefit from cutting out dairy. So if you want to try, exclude it for a period of sort of between 2 weeks and 6 weeks, and see if you experience a benefit, and then bring it back in to see if you notice then it worsened. And that's a really good to go through a structured exclusion process, because you don't want to have a really restrictive diet unless you need to. And it can start to lead to disordered eating, and a sort of just make it all feel like it's very hard work unnecessarily. And similar for gluten, really. And the evidence is whether it may.
Oh, you've just frozen for a minute there, I'm afraid, Adam and Grace. Really, lots of really interesting questions coming through. Oh, you're back again. That's great.
Okay.
You just froze for a moment there. We have another question here.
Can I just
Yeah,
sorry, just on. I know Grace was just going to come on to say about gluten. Of course, if you think you might have celiac disease, so and so if you exclude gluten, I mean, you're best to talk about it than me. But if you feel better, there's a small chance you could have celiac disease when it really is important to avoid it. And we are seeing that, aren't we? And some people who don't necessarily have the sort of the classic symptoms and are having this undiagnosed, and we're making the diagnosis. And so if you do find actual celiac disease,
so and as Adam said, it's really important to know that you don't always have to have digestive symptoms or a classic adverse reaction to wheat to have celiac. There are other very non-specific symptoms. So, and particularly if you've had a miscarriage, or you've got prolonged infertility, or indeed if you do feel you have a reaction to wheat, there's a simple blood test you can ask your GP for. So it's really, really important, because then you do absolutely really strictly including the need to avoid cross-contamination food and everything. So
and the other thing is, of course, one of the symptoms of polycystic ovary syndrome is thinning of the hair on the head, which isn't only due to hormone problems. It can be due to nutritional issues, and could be a pointer towards a problem such as either iron deficiency. So some women who have very heavy periods are low in iron. That can affect the hair on the head. And similarly, the malabsorption that you have with celiac disease can affect the hair on the head. So if I have a woman with PCOS, I'll always do those other tests as well, just to make sure we're not missing something.
That's really interesting. Thank you. We've got a question now which we were sent in earlier from someone who's 35, has lean PCOS without periods, had a failed round of IVF with lots of eggs and embryos, but not good quality enough to freeze at day 5, asking, is poor quality eggs a side effect of PCOS, or would that be overstimulation of the ovaries?
It's probably a bit of both, really, because it's the women with polycystic ovaries, as we said earlier, whether or not you've got the syndrome, who tend to over-respond or respond very sensitively to the drugs that we use during IVF. So you get more eggs, you may get more immature eggs, and that in turn can lead to lower fertilization of those eggs and a reduced chance of getting pregnant. So it's a constellation of things, and there are a number of nutritional factors that can influence the health of the egg. And whilst we know that if you have hormones to stimulate the ovaries, whether it's in a natural cycle, it's 2 weeks for the follicle to grow and to ovulate, because ovulation is often on day 14 of a 28-day cycle. Or if we're doing IVF or giving drugs to stimulate ovulation, then again, it's sort of 10 to 12 days or so to get a follicle to grow. But that's not the whole story. That's the very last part of the journey of the egg. So the follicle has grown in those 2 weeks or so, but the eggs you were born with, number one, but also the egg started on that journey several months ago. We don't know exactly how many months, but at least 9 months previously, prior to ovulation, that egg is getting ready. So you can influence, and this is why, you know, you talk about this a lot, don't you? The sort of the need to think long term. It's not just that month of your IVF treatment or your ovulation induction treatment. It's long term, because that's what has an effect on the health and the quality and the fertility.
Oh, you've just frozen again there, Adam and Grace. I hope that you come back shortly. It's going to go on to the... Can you hear me, Adam and Grace, again?
Yes, yes.
You just froze briefly there.
Okay, sorry about that.
No, don't worry.
We can hear you the whole time.
Good.
I mean, we're in London, which is...
out in the sticks for Wi-Fi.
I mean, when we're up in Yorkshire,
It's
often,
fine,
yes,
it's fine.
exactly.
Now, I had another question for you from someone here, which is, which fertility treatments are useful for women with PCOS who do ovulate and have regular cycles? Is Clomid helpful here, or is it pointless if you're already ovulating? I think that's a really good question, actually.
And before we just go, just in terms of the last question, so if somebody isn't having periods and they've got poor egg quality, there are things that they can look into. So having sort of mineral testing, things like zinc. So you need zinc to trigger your eggs from that developmental arrest into the development pipeline, and zinc is important for the egg to go through that development process during that 9 months. So it's worth having some nutrient testing, looking at that. And there are other things for that person, and antioxidants such as can you still hear us? Our connection is and antioxidants like coenzyme Q10. So there are various things that you can do in that respect. So there's more information on the book on this kind of thing, actually. So.
Brilliant, that's great, thanks. So about the treatments, is Clomid helpful, Adam, if someone's got regular cycles?
If somebody has a regular cycle, there is nothing gained by giving any medication to stimulate the ovaries. Okay.
Yeah.
If you're not ovulating, if you have an irregular menstrual cycle, there's a sort of a stepwise approach, and you've kindly mentioned the book. I'll mention it again, the Fertility Book. But basically, the Fertility Book goes through this step by step. So the sort of lifestyle things we're talking about are fundamental, and then drugs to stimulate ovulation. Clomid or clomiphene, the same name for this, different names for the same drug, isn't used so often these days. It works, and it was used for many years, but these days we prefer to use a drug called letrozole, which is also a tablet and gives a better chance of a pregnancy than Clomid. So we start off with letrozole at a low dose. In our clinic, we monitor with ultrasound. It's the gold standard to monitor with ultrasound, not only to make sure that you're responding but also to ensure that you're not over-responding, because one of the risks of any of these drugs is multiple pregnancy, and multiple pregnancies bring all sorts of additional hazards to a pregnancy. So letrozole is the first line. If you don't ovulate in response to letrozole, then we move on to hormone injections when the active ingredient is FSH, follicle stimulating hormone. Sometimes we do an operation called ovarian diathermy, which isn't done that much in the UK because the drug treatment tends to work very well. And high-tech treatment such as IVF is really a last resort, unless you're found to have blocked fallopian tubes or your partner has a low sperm count. So IVF is at the bottom of the list. So it's very important, if you're having problems with an irregular menstrual cycle, that you're seen in a specialist fertility clinic who can offer you the sort of drug treatment monitored safely that I've just been talking about.
That's really interesting, actually. So if you're having any irregular periods, it's worth getting referred as quickly as you can.
Yes, yes.
Another question we have here is from someone who's done 3 ICSI cycles with their own eggs and is now starting a cycle with donor eggs. She wanted to know about maintaining a pregnancy with PCOS and what additional risks, if any, she might face. Are there additional risks in pregnancy with PCOS?
Yes, I think there are, and I think we could both answer this. So polycystic ovary syndrome affects your whole body, and when we're talking about pregnancy, the metabolic things, if you're overweight, will affect a pregnancy. And also in the context of egg donation treatment, it may not be your eggs, but those fertilized eggs are going into your womb, and it's the womb, the health of the womb, and the lining of the womb in particular that's important for implantation and setting the scene for a healthy pregnancy. So, Grace.
Yeah, so really important. So women with PCOS are disproportionately affected by things like low vitamin D and some of the other minerals that I've mentioned in terms of zinc and magnesium. Iodine is also really, really important for ovarian function. So if you don't eat fish, or if you're a vegetarian, or you're cutting out dairy, you can be classically low in iodine. So there are various sort of dietary factors that can support any sort of medical treatment. There's a small study to show that Inositol may be beneficial, but it hasn't been widely tested during pregnancy. There's no evidence to suggest at all it's harmful, but you should only consider things like that under the supervision of your treating doctor. So talk to your doctor about things like that, but certainly making sure you've got enough vitamin D, enough dietary intake of iodine, or a good pregnancy supplement is important, and just that sort of healthy diet with lots of fruits and vegetables and so on, so that you're not contributing to things like the insulin spikes and the oxidative stress through an unhealthy diet and lots of sugar and so on.
We actually had a question about that, about inositol, whether you would recommend that, or is it ovasitol? Would you recommend those?
So do you want to say anything? So I mean, so I think in terms of sort of the official medical literature, and certainly last time Adam had a review, I think the conclusion was there wasn't a sort of sufficient evidence base, but the evidence has built since that review was done. And I think what it can be very useful for is, it can be very helpful for PCOS, but what I find is that if you manage all your other nutrient levels first, including things like zinc and vitamin D, what can happen if you've been on the pill, anything that contraceptive pill, anything that increases estrogen in the body, so that's include pregnancy, and the pill can increase the absorption and retention of copper in the body, and that can push zinc down. And because you need zinc for your eggs to develop and for ovulation and so on, that can set you up for more problems. If you've come off the pill and you have PCOS, you may well have a sort of low level of zinc, and that can exacerbate the problem. So making sure that you have sufficient levels of all these key nutrients that we're talking about, your zinc and magnesium and vitamin D and iodine and so on, either through diet or supplements. And then if you add in inositol after that, that's when we tend to get the best results. And a combination of good diet and exercise, you start to sort of accrue marginal gains across all of these different things, and we then start to see women respond very well, including increased regularization of the menstrual cycle, ovulation where women were ovulating before, and so on and so forth, and natural conception where women have been struggling. So if you can do it sequentially and take on board everything that we've talked about, and according to the global guidance, lifestyle is the first line intervention for PCOS, but it's just often isn't done well.
Well, the question was also about, if you're having donated eggs.
Yeah.
So the point is, it's your whole body.
It's your whole body during pregnancy that will still have it.
And the one vitamin we haven't mentioned, it's not so specific for PCOS, of course, is folate, isn't it?
Yeah.
Because folate is important, and of course there's been some news recently about flour being fortified in the UK. So folate's important for the development of the baby, and if you're overweight, then you need a higher dose of folate as well. So don't forget that. So it's not specific for PCOS, but it's, we shouldn't not mention it.
Yeah.
Adam, there's a question here that I think is for you. How many cycles of letrozole would you recommend before moving on to FSH injections?
So it depends whether you're ovulating or not. Okay. So if you're not ovulating, you move straight on. So basically, we try a low dose, the next dose up. If you're still not ovulating, you move on to FSH injections. If you are having letrozole and you're ovulating, then we usually leave it 6 cycles to enable you to get pregnant. So that gives you a good chance. After 6 cycles of letrozole, you should have easily a 65-70% chance of having an ongoing pregnancy. But if you're ovulating and not pregnant, there's nothing gained by giving a different form of drug to stimulate ovulation. That's when you would move on to IVF.
Great, thanks. Another question here from someone who said it's been suggested that she takes Inofolic Alpha. She says she exercises regularly, eats well, doesn't drink. Is there anything else she should be doing?
Look, I think it sort of feeds into what Grace was just saying, because Inofolic is basically the combination of inositol and folate.
Right, okay.
It's sort of a neatly packaged, and there are all these different things that are available. Yeah.
But making sure everybody should be taking vitamin D, particularly during the winter for fertility and pregnancy. So that's really important as well.
And that's men and women.
Yeah. And men and women often mirror each other in terms of test results because you have similar diet and lifestyle. So always consider the partner, as Adam mentioned before.
This is a question from someone who says, what can I do if my consultant has said letrozole offers no advantage to Clomid, and they've said the only other option is IVF if Clomid doesn't work? I mean, is there anything people can do if their fertility specialist is giving maybe not the most up-to-date information?
Yes, well, I think, as Grace said, show them our book.
It's all mapped out very carefully.
But there are guidelines out there, there are written guidelines. Excuse me. And so,
absolutely.
There are PCOS guidelines. There's the Global PCOS Alliance. There's the World Health Organization guidelines that I wrote. And, excuse me. So basically, I appreciate it's always difficult challenging a doctor. But I have to say, I have lots of people who come to me asking me questions. I'm always happy to have a debate and be challenged. And we should, we're here to be challenged. And I think if you feel you've hit a brick wall, and I'm sorry if that might be the case, then maybe you should ask to be referred to somebody else. And we do see that people go from clinic to clinic. I appreciate there are practical and geographical limitations, particularly depending upon where you may live. But essentially, the way things work in the UK, we have big teaching hospitals like ours that have dedicated reproductive medicine units that will provide the whole range of treatments, including IVF. And then we're, if you like, a hub. And then there's a spoke, the district general hospitals, who will have a busy gynecology department, maybe with one consultant who's interested in infertility, and they will feed into the hub. So if you feel that you're in one of those sort of peripheral units, ask to be referred to a major centre where you should be offered the most up-to-date advice and help.
Adam, someone's just asked if we could circulate the guidelines. Would you be able to send me the links afterwards so that we could maybe put them online when we put the webinar online afterwards, which will go on our webinars page, and then we could maybe add the link to those WHO guidelines that you were talking about so that people can, if they want, take them to their specialist to show what we're talking about.
We'd be very happy to. Yeah.
Brilliant. We've just had another question. Would letrozole also regulate periods?
Yes, probably it would. But we don't use it to regulate periods if you're not trying to get pregnant, simply because it needs to be monitored. So if you're not trying to get pregnant, other ways to regulate, there are other medications to regulate the cycle.
Okay, we had a question about a link between PCOS and COVID. Is it true that you're more likely to get COVID if you have PCOS? Is that true?
Yes, there is some evidence for that. I think the issue is that the Polycystic Ovary Syndrome is associated with inflammation. It can be associated with reduced immunity and thereby an increased risk of developing COVID. And of course, as we were saying earlier, the metabolic problems, particularly if you're overweight, put you at increased risk. So this really reinforces the need for all of us to get vaccinated. We are seeing in the UK, sadly, women in pregnancy who are becoming seriously ill with COVID if they haven't been vaccinated. And that not only jeopardizes their lives, it jeopardizes the life of their babies. And we're sadly seeing a lot of very, very heartbreaking stories in the UK. And there is no evidence that having the vaccination affects male or female fertility. There is some evidence that it may cause a slight change in your menstrual cycle, as any vaccination or any illness or anything can actually have a short-term effect on your menstrual cycle. But there is no evidence and there's no logical reason why the COVID vaccination should have any long-term effect on your fertility. And there's clear guidance on the British Fertility Society website about COVID and vaccination. So it's, you know, it's a good opportunity for me to just sort of bang the drum, if you like. Please get vaccinated. It's the only way out of this crisis.
Thank you. We have been asked about a link to your book. We will put that with the, when this goes online, we'll make sure there's a link to the book as well. Someone's just asking, would you recommend Dionet or Yasmin to block male hormones?
So Dionet and Yasmin are two forms of the combined oral contraceptive pill. So the combined pill means it's a combination of an estrogen and a progestogen. And there are different forms of progestogen, and any combined pill will help regulate the cycle. And in reality, any combined pill will help suppress the androgens, will suppress testosterone, and also will raise a protein that mops up the testosterone as well. So any pill will work. Traditionally, Dionet and Yasmin have been offered, and there are different brand names for the same combination, have been offered for PCOS because the progesterone that's in their preparations have anti-androgenic properties. So they can be helpful. The reality is the evidence suggests that any pill is probably will have the same sort of effect, and we like to use a pill that has the lowest dose of hormones to achieve that effect. So the straight answer is yes, they can help, but any pill will do, and we try to use low dose pills these days.
Okay, there's a question here from someone saying that their clinic started them on Clomid before Letrozole and allow for a total of 12 medicated cycles. They've had 9 Clomid cycles, but ovulated but no pregnancy, can now only do 3 Letrozole cycles. But would you say that 6 cycles of Letrozole might still be beneficial? So should they do more than the 12 in total?
I wouldn't say so, no.
Okay.
It depends, no, I mean, 12 is, you know, in a sense, you're lucky to have 12. The evidence is that the cumulative chance of getting pregnant starts to plateau by the time you've had 9 or 12 cycles, and then you should really be thinking about moving on to IVF. Age has an impact on all of this as well. Obviously, the older you are, the longer it's going to take to get pregnant, whether it's with treatment or naturally.
Someone here saying that it might not be relevant, but for them, their PCOS started after getting COVID vaccines and they hadn't had it before. Can that ever be relevant, Adam?
I can't see any mechanism why the COVID vaccine should have precipitated that. And of course, Polycystic Ovary Syndrome is common. Millions of people are getting the COVID vaccine, and PCOS can evolve over time. And actually, I'm seeing quite a lot of patients who during COVID and lockdown have been more sedentary, so they've not been able to get out and exercise, and so that can tip the balance and precipitate the symptoms of polycystic ovary syndrome. So I would say that's a coincidence. I've certainly not seen a flurry of people with a new diagnosis of PCOS after the vaccine.
Someone saying when they started trying to conceive, they weren't ovulating. Now they're ovulating, having regular cycles, but still not able to get pregnant after 18 months. Are there any further tests or treatment they should look at beyond the ones they had initially? Tubes are okay.
Well, I suppose I don't know all the tests that have been done, but assuming the hormones are okay, you're ovulating, your tubes are okay, assuming you're in a heterosexual relationship, your partner's sperm's okay, then that would be over to Grace to just drill in and look in more detail at the nutritional, metabolic, you know, you mentioned the microbiome earlier.
Yeah,
I don't know if you want to
so there's lots of different components to this, and we often help women conceive naturally. It doesn't always happen, and you may still need IVF, but it's certainly worth looking at, you know, getting some nutrient testing done, so that your minerals tested, things like, you know, your zinc, as I mentioned before. Manganese can impact ovulation, and so there's lots of different nutrients that can have an impact. Make sure your vitamin D is okay. All the dietary stuff we've spoken about, exercise, making sure you've got enough iodine, all of those things. So I think it's definitely worth looking at all of those aspects, and for both men and women, as we've talked about, because the male factor may be contributing, and then if that's still not working for you, to look towards that.
And also, you know, there's what we call unexplained infertility. So you can have polycystic ovary syndrome, everything else may be fine, you may sadly still not be getting pregnant. There are still lots of areas of research, for example, in the endometrium, so that's the womb lining, and other things that may be helpful. Also the genetics of eggs and sperm. You know, there's a lot there that we're exploring, some things that we don't know, and you know, so there's still work to be done.
Yeah, sorry, in terms of the gut bacteria. So any digestive symptoms, and again, this goes to anybody trying to conceive, always investigate those. So you're sort of a healthy digestion indicates that you're, you know, digesting and absorbing the nutrients from food well, and making sure that you're eating a healthy diet will help the sort of gut bacteria, which can impact your hormone levels, and eating probiotic foods, so fermented yogurts, things like kefir, sauerkraut, kimchi, and so on. Those can all, again, support sort of general health and sort of reproductive function.
Grace, another question for you, I think here. What's the link between high cholesterol and PCOS, and how can we lower cholesterol levels?
Well, I mean, the generally women with PCOS can have underlying sort of features in terms of their sort of lipid profiles as well, that sort of link to their sort of cardiometabolic risk factors. In terms of lowering cholesterol, so obviously dietary sort of factors, sort of not having too higher dietary intake, and managing, so not having too high fat. Some people try ketogenic diets, which are obviously very high in fat, which should be avoided. So having a balanced intake of your sort of protein and carbohydrates and healthy fats. And obviously there are medications that you can use to lower cholesterol, including statins. But you need to have obviously a blood test to check to see whether your cholesterol is high in the first place. But there are also other things like niacin, which is vitamin B3, can help reduce cholesterol levels. But again, you need to make sure that you have that as your starting point. Don't self-medicate unless you know that's an issue for you. So, and you can get that tested through your GP.
Another important question, I think, is stress and anxiety making PCOS worse? I think people worry about stress and anxiety with pretty much any fertility related issue at the moment, but I wonder what you both think about that.
Let's start. Yeah.
Yes, I mean, all of the things that we've been talking about are stressful and anxiety provoking, and you know, there's a little bit of controversy actually, the degree to which stress might actually be stopping you from getting pregnant, but there's no doubt that there are so many components of the fertility journey that exacerbate stress, not least of which, if you're having problems with ovulation, when are you ovulating? When should you be having intercourse? And this whole issue of the dynamics of relationships, having intercourse, you know, prescribed sometimes by a doctor. If we're doing ovulation induction, you should be having intercourse today or tomorrow. And that in itself causes more stress. So all of these things, you know, exacerbate the situation. And there are many ways to help de-stress, both by hopefully having you know, a supportive team in your fertility clinic. You know, our nurses are wonderful. I would say this, but I think Grace is wonderful, the way she looks after couples coming to see her, just to help provide support, because support is important. And then there are other ways of achieving support that may help reduce stress, whether that's by exercising or going to yoga classes. Sorry, I'm treading on your toes a little bit.
We can interchange.
Meditation and mindfulness can help. Those sorts of things can be beneficial. acupuncture may help reduce stress. There's mixed evidence as to the degree to which acupuncture may actually boost fertility, but it can actually be, helpful as part of, everything that you're doing. But one thing, whilst we're just mentioning acupuncture, please do not use Chinese herbal medicine. That can cause problems, can be dangerous. So, I'm not because it's not regulated or controlled in the way that other drugs are in the UK. So acupuncture, fine. I mean, do you want to add to that?
So I mean, just to sort of echo, evidence is mixed. Obviously, if you're, all the sort of physiological impacts of stress in terms of when your cortisol, which is your stress hormone, goes up, it has the impact that, affect lots of different pathways. But there's lots of debate. But I think the important thing is you want to manage your mental health and well-being and your sense of feeling sort of emotionally well, just as much as you want to manage yourself physically. And it's really, really important. So, regardless of whether it has an impact, and certainly if you want to conceive and you want to go on to be a parent, taking care of yourself well is incredibly important. So all of the things Adam mentioned in terms of things like yoga and meditation, but I think it's just also going easy on yourself. Don't beat yourself up. I've had this food and I've had a episode of binge eating, or I've eaten too much chocolate, or whatever it may be. I think be kind to yourself and get into this space where you're really nurturing yourself. It's so important. And if you need support, you can speak to your GP. There's Fertility Network UK. There's lots of different counselling through your fertility clinic. There's lots of different avenues for support. And so I can't stress enough just to really take care of yourself. Don't give yourself a hard time, and seek support if you need it.
Brilliant.
If I may also include Verity, of course. Verity are the national PCOS support organisation that obviously complement Fertility Network UK, but they have a lot of useful information specific for people with PCOS on their website.
We're running out of time really. We've just got a few minutes left, unfortunately, and I know there are lots more questions that we haven't answered. We'll have Adam and Grace back another time, I think, to do this subject again, because it's such an important thing. But just one last thing, Grace, which is about the nutritional tests and whether you can get them on the NHS, because obviously not everyone can afford to pay privately for this kind of test. Someone saying here, my GP wouldn't even test my progesterone recently, so I imagine they'd laugh me out the door if I asked for nutritional tests. Can you get those tests on the NHS ever?
So at the moment, obviously we have a national sort of test tube shortage, so at the moment no, but the ones that your GP can do if they're willing to do so, and you can try, so vitamin D, you can ask for zinc, copper and selenium. You can ask for, some will do things like vitamin A and omega-3, folate and B12. Your GP can also do. Whether or not they will, is another question, but those are the ones. And I would encourage you to ask when the test tube sort of shortage sort of alleviates, because it's just incredibly helpful for you to get a handle on what your levels are, how you're responding to diet, how well you're absorbing nutrients. Ferritin is another one, which is your iron store. Your GP will do that, so that's really important. And just a very quick one on folate. So if you've been supplementing with folic acid and your folate is low on testing, you may have problems converting folic acid into folate. So you may have a mutation called MTHFR, and sometimes we see it's very low after a prolonged supplementation, and then you would benefit from supplementing in its natural form folate. So it's just something to bear in mind. But always ask to see your results. Things that fall into the normal reference range may not be optimal for fertility, pregnancy, and conditions like PCOS. So if it's the low end of the range, you may still benefit from either dietary changes to increase those nutrients or supplementation.
That was absolutely brilliant. Thank you both. You've been absolutely amazing. I've certainly learned absolutely masses this evening. I'm sure everyone else has. So thank you, Adam and Grace, for joining us. And thank you to everyone in our audience as well. I hope you found it as helpful and informative as I did. Just a reminder that you'll be able to find the recording of tonight's webinar and those useful links on the webinars page of our website within the next week or two. And finally, don't forget, we're your charity. We're here for you. Everything we offer is completely free of charge. We've got a wide range of support groups right across the UK, and our support lines open every weekday from 10 to 4. So do get in touch if we can help, and check out our webinars page for the details of our next webinar coming up in October. Thank you very much, everyone. Take care and see you all soon. Bye.
Bye.
Bye. Thanks.